Hello and welcome to another intensivecareathome.com and intensivecarehotline.com live stream. My name is Patrik Hutzel and I'm the host of your show. So today's topic in this live stream is COPD in ICU, ventilation, tracheostomy, and evidence-based home care with 24-hour or 24/7 ICU nurses at home. That's what we will be covering today. Some of the major topics we will be talking about is obviously COPD in ICU, tracheostomy, BIPAP ventilation, CPAP ventilation, mechanical ventilation, home ventilation, intensive care at home, ICU nurses at home, critical care, long-term ventilation, home care, and also very important, quality of life. So we'll be breaking up this live stream today into two sections. The first section is COPD in hospitals, in ICU in particular, whether it's long-term ventilation with tracheostomy or whether it's non-invasive ventilation such as BiPAP or CPAP. For COPD patients in ICU, we're talking about tracheostomy procedures and management. And then when mechanical ventilation becomes necessary, ICU challenges with COPD patients, non-invasive ventilation in ICU, BiPAP and CPAP. That's what we are covering in the first part of this presentation. And in the second part of the presentation, we obviously talk about COPD, discharge home from intensive care with intensive care, nurses 24/7, evidence-based mechanical home ventilation guidelines, 24/7 critical care registered nurses at home to make that transition from ICU possible, community access and quality of life improvements at home, and non-invasive ventilation at home, BiPAP or CPAP. So why does this matter today? Because simply there's a lot of COPD patients stuck in ICU long-term, and they don't know where to go, and they're often being told by intensive care units that, they won't have any quality of life at all, and that we should just stop treatment, and because there's nowhere to go to for them, and nothing could be further from the truth. Because with intensive care at home, we can provide quality of life at home for long-term ventilated COPD patients, whether it's with tracheostomy or without tracheostomy on BiPAP or CPAP ventilation. So also, if you enjoy my videos, if you enjoy my YouTube channel, and if you find value in what I'm doing here, like the video, subscribe to my YouTube channel, hit the notification bell, and share the video with anyone that can or will benefit from the information that I'm sharing here. I also want to welcome everyone on this live stream. I also want to welcome the viewers that watch this video on replay, because I know we get quite a few viewers on replay. Now, also, my name is Patrik Hutzel. I am the host of this show today. What makes me qualified to talk about COPD in ICU and then talking about COPD patients at home with intensive care at home? I'm a critical care nurse by background, having worked in critical care nursing for over 25 years in 3 different countries, where I worked as a nurse manager for over 5 years, and where I've been consulting and advocating for families in intensive care since 2013 all around the world. I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we are sending our critical care nurses into the home 24 hours a day for long-term ventilated adults and children with tracheostomies, BiPAP and CPAP ventilation at home without tracheostomy, tracheostomy care without ventilation, cough assist management at home, ventilation weaning at home, TPN, home IV potassium, home IV magnesium, home IV antibiotic infusions, central line, PICC line, Hickman's line, as well as port management at home, PEG, PEG tube management at home, nasogastric tube, nasojejunostomy tube management at home, as well as palliative care services at home. We also manage suprapubic catheters at home and indwelling catheters at home. So today, and we're also providing level 2 and level 3 NDIS support coordination with intensive care at home, and we're also providing TAC and WorkSafe case management. So today's topic is COPD in ICU with long-term ventilation and tracheostomy or BIPAP, CPAP, and most importantly, how patients can transition to evidence-based intensive care at home if they're stuck in ICU long-term with COPD. And, invasive ventilation, tracheostomy, or with non-invasive ventilation, such as BIPAP or CPAP. Now also, drop your comments in the comment section. If you have any questions, please stay on topic. If we have time at the end, we can, we can cover other topics as well. But if you can keep your questions to today's topic, which is obviously COPD in ICU or COPD at home with intensive care at home. If you have any topics you want me to cover, please type them in the chat pad as well. We'll probably be going up to an hour, depending on how quick I can get through my presentation. And if we have time at the end for questions, you're more than welcome to ask them, of course. But if, like I said, if there's any topics you want me to cover, please type them into the chat pad. So in the first half of the presentation, we'll focus on COPD in ICU settings, what happens when COPD patients require long-term mechanical ventilation, when a tracheostomy becomes necessary, and the role of non-invasive ventilation like BiPAP and CPAP. And in the second half of this presentation, we'll explore the game-changing option of intensive care at home, how COPD patients with ventilation and tracheostomy can safely discharge home with 24/7 critical care registered nurses, enjoy community access, and live a dramatically better quality of life compared to staying in ICU. Today's information is absolutely crucial, whether you or your family member in ICU, and if it's a family member, you're obviously the advocate watching this for your loved one, or if you're a patient yourself or a healthcare professional watching this, you might be a doctor or a nurse in ICU, or a respiratory physician in ICU, might be a respiratory physiotherapist or a respiratory therapist watching this, and you might know patients that would benefit from intensive care at home. We're all probably here to improve the quality of life for either our patients or for our family members. That's probably why we're all here. Now, again, if you haven't already, subscribe to my YouTube channel, hit the like button, hit the notification bell, and share this video with your friends and families who can find value in this. Now, I publish evidence-based content here regularly to help families in intensive care navigate critical care situations, which obviously includes intensive care at home. And if you find value in this information, please let me know and share it with someone who needs this information. So let's get started. Understanding COPD in ICU. That's the first thing we want to look at. Let's begin with the basics. COPD stands for chronic obstructive pulmonary disease. It's a progressive lung condition that makes breathing increasingly difficult. It includes conditions like chronic bronchitis and emphysema. When COPD patients experience acute exacerbations, they often end up in ICU. These exacerbations can be triggered by infections, environmental factors, or the natural progression of the disease. In ICU, COPD patients may require respiratory support ranging from supplemental oxygen to full mechanical ventilation. The goal is to reduce the work of breathing, improve oxygenation, and give the lungs time to heal and recover. But here's what most patients and families don't realize. When COPD patients require prolonged respiratory support, we're talking about weeks or months here. They often face a choice between remaining in ICU indefinitely or considering a tracheostomy with long-term ventilation. Or they might be requiring BiPAP or CPAP ventilation without tracheostomy. They might also be requiring airbow or high-flow nasal prongs to help them with COPD. And this is where our conversation becomes critical today, because many families or patients in ICU are told their only option is institutionalized care. But that's simply not true. And we'll talk about the alternative in the second half for today's live stream. First, let's understand what happens in ICU. So let's look at non-invasive ventilation options first before we talk about invasive ventilation with the tracheostomy. Let's discuss non-invasive ventilation, specifically BiPAP and CPAP. Let's start with CPAP. CPAP stands for continuous positive airway pressure. It delivers a constant level of positive pressure to keep airways open. It's commonly used for sleep apnea, but can also help COPD patients, particularly those with overlapping conditions. And CPAP is delivered with a ventilator, with a mask, with a face mask or a nasal mask. And it only delivers one level of pressure. It only delivers a PEEP, right? And that PEEP can manage high CO2 levels. One of the issues with COPD is simply that CO2 levels are rising, right? Carbon dioxide levels, it's also known as hypercapnia. If CO2 levels are rising and are not managed appropriately, there can be confusion as a side effect. There can be drowsiness, sleepiness, confusion, and a change in the pH in the blood. If someone is hypercapnic, has CO2 retention, their pH becomes acidic, and that's not and that can impact other organs as well. So bringing CO2 levels down during COPD episodes of COPD patients is critical. So let's now look at BiPAP, which stands for bi-level positive airway pressure, similar to CPAP. It's being delivered by a ventilator. It's being delivered with a face mask, and it's more commonly used for COPD. It provides two levels of pressure: higher pressure when you breathe in, lower pressure when you breathe out, two levels of PEEP, basically. And this makes breathing easier and reduces the work of breathing for COPD patients. In ICU, BiPAP is often the first line treatment for acute COPD exacerbations. It's non-invasive, meaning no tube down the throat, and it can prevent the need for intubation in many cases. And you should prevent intubation whenever you can. This is also where, when patients are on BiPAP, they also need a break from BiPAP. That mask is very uncomfortable. People need to eat, drink, brush their teeth, whatever the case may be. And that's when, for example, a high-flow nasal cannulas come in, like the Airvo, right? That can also help with COPD, but probably not quite as effective as BiPAP or CPAP, but it can still be assisting in managing COPD. The challenge with COPD is that some patients develop what we'll call BiPAP dependency. They do well on BiPAP, but struggle without it. These patients may need BiPAP for many hours daily or even continuously. And here is what's important: BiPAP and CPAP are not just ICU or hospital treatments. With proper support from 24/7 critical care registered nurses at home, COPD patients can safely use BiPAP or CPAP at home, maintaining their respiratory function while living in their own environment. And this is exactly what we do with intensive care at home. We provide that 24/7 critical care nursing support and that expertise so that patients can manage non-ventilation safely at home. We'll dive deeper into this in the second half of this presentation, but just for you to understand what is required. For now, remember, non-invasive ventilation is a viable long-term option for many COPD patients, but it requires expert nursing care, especially when used continuously, right? And that's what I've seen in ICU over and over again, that many COPD patients start off on BiPAP. They might even start on the high-flow nasal prongs. If that doesn't work, they go on to CPAP. If that doesn't work, they might then go on to BiPAP, right? And if that doesn't work, then unfortunately, they might need intubation. But again, the goal is to prevent and avoid intubation at any cost, really, ideally. Okay, let's move on to the next part of this presentation, which is obviously if BiPAP, CPAP, high flow nasal cannula, high flow nasal bronchs, or airvo fails, that's when invasive ventilation might become necessary. Now let's talk about invasive mechanical ventilation. What happens when BiPAP isn't enough? So when a COPD patient's respiratory failure is severe or when non-invasive ventilation fails, the ICU team may recommend intubation. This means inserting a breathing tube through the mouth into the trachea, into the lungs, and connecting it to a mechanical ventilator. The indication for that is often deteriorating respiratory function, such as high respiratory rate, low oxygen saturation, high CO2, high carbon dioxide, right? And increased drowsiness, increased confusion, and basically patients are close to having a respiratory arrest, right? Poor arterial blood gases would be another sign, if blood gases are being measured at this stage. So the ventilator then breathes for the patient or assists their breathing, taking over the work their lungs can no longer manage effectively. Patients, unfortunately, then need to be induced in a coma, so that mechanical ventilation can be tolerated. Okay, so then, and that comes with many side effects. You don't want your loved one being in an induced coma. It comes with a lot of side effects such as deconditioning, muscle wastage. And with deconditioning and muscle wastage, it's getting then very difficult to get off the ventilator, especially when mechanical ventilation is prolonged. And I can tell you again from my own experience, having worked in ICU for so long, it can be very difficult getting COPD patients off the ventilator, right? Therefore, the ventilator then breathes for the patient or assists their breathing. Taking over the work for their lungs can no longer manage effectively. For COPD patients, intubation is always a serious decision because, number one, COPD patients are difficult to wean from the ventilator due to their underlying lung disease, right? Whether it's emphysema, chronic lung conditions, the lungs are stiff, and therefore it's difficult to wean someone off the ventilator with stiff lungs. Number two, prolonged intubation increases risks of ventilator-associated pneumonia and other complications such as barotrauma, pneumothorax, and the rest of it. Number three, the longer someone remains intubated, the harder it becomes to remove the breathing tube. This is why ICU teams try to avoid intubation when possible, using BiPAP first, but sometimes there is no choice. If a COPD patient remains intubated beyond 7 to 14 days, the medical team usually begins discussing tracheostomy. Usually, this is a pivotal conversation that families need to understand fully. Many families fear tracheostomy, thinking it means their loved one will never breathe normally again. Others see it as the end of the road. But I want to reframe this for you today. Tracheostomy can actually be a bridge to a much better quality of life, specifically a bridge to going home with proper intensive care support at home. But let's talk about what a tracheostomy actually involves. So tracheostomy for COPD patients, or tracheostomy in COPD management. A tracheostomy is a surgical procedure where a hole is created in the front of the neck into the trachea, and a tracheostomy tube is inserted. This provides a direct airway bypassing the mouth and throat. For COPD patients requiring long-term ventilation, tracheostomy offers several advantages over prolonged intubation. First, it is more comfortable compared to a breathing tube. If you are watching this and you have ever seen your loved one with a breathing tube in their mouth, or God forbid you had one yourself, it is very uncomfortable, and that's why patients require an induced coma, right? With a tracheostomy, Patients can often communicate easier, sometimes eat and drink, and move more freely with a tracheostomy compared to having a breathing tube through the mouth. Number 2, it reduces sedation and opiate requirements. Patients on tracheostomy ventilation can be more awake and interactive. They can also be mobilized much easier. Number 3, it's safer for long-term use with lower infection risks compared to prolonged oral intubation. Number 4, it facilitates weaning trials and respiratory therapy. Now, here's the crucial point. A tracheostomy with mechanical ventilation requires specialized nursing care 24/7. A tracheostomy can only be managed with nurses that have worked in critical care nursing for a minimum of 2 years. And really, what it comes down to, it can only be managed safely in a traditional hospital ICU setting, which means remaining in the hospital almost indefinitely or transferring in the US, for example, to a long-term acute care facility, which we don't recommend full stop. But, and this is where it gets important and where the rubber hits the road, with 24/7 critical care registered nurses or ICU nurses, COPD patients with tracheostomy on ventilation can go home with intensive care at home, right? And this is by no means experimental. This is evidence-based care backed by established evidence-based mechanical home ventilation guidelines. Our clients at Intensive Care at Home prove this every single day. We've proven it since 2012 with Intensive Care at Home. Other organizations in other countries, such as Germany, Austria, Switzerland, France, Italy, have proven it since the late 1990s that, you know, patients from intensive care can go home safely with intensive care at home services as long as equivalent services are being provided in the home, i.e. 24/7 critical care trained nurses. And what I haven't mentioned early on is, you know, I have worked in critical care nursing for over 25 years in 3 different countries, and I was fortunate enough in the early 2000s to become part of a startup service in Germany where we were the first ones basically taking intensive care patients home on ventilation and tracheostomy. And, you know, I've been exposed to intensive care and intensive care at home for a long time. I argue there are not many people out there who have seen as many ventilated and tracheostomy clients in the community like I have. So, you know, and I've seen thousands of patients in ICU and I've seen hundreds of patients in the community with ventilation and tracheostomy. Now, before we transition talking about home care, let me address the reality of long-term ICU stays for COPD patients with ventilation, because that reality is pretty bleak. That reality is pretty bleak, like for any long-term ICU patient, really. So let's look at challenges of long-term ICU care for COPD and the reality of extended ICU stays. Let's be clear about what long-term ICU means for COPD patients on ventilation. Number 1, hospital-acquired infections. The longer a patient stays in ICU, the higher the risk of infections like MRSA, C. diff, and other resistant organisms. Number 2, muscle wastage and deconditioning. ICU patients lose muscle mass rapidly. Extended ICU stays lead to severe weakness, making recovery harder, sometimes impossible. Number 3, ICU delirium and ICU psychosis. Prolonged ICU stays are associated with cognitive decline, confusion, and psychological trauma. And the trauma extends to families as well. Number 4, limited family interaction. Even post-COVID, ICU visiting hours are restricted. Patients miss out on crucial family support and social connection. Number 5, loss of dignity and autonomy. ICU patients have minimal control over their environment, routine, or daily decisions. And number 6, no community access. Patients are confined to an ICU bed with no fresh air, no outdoor time, no daylight, no natural daylight, no community engagement. And here's what families are telling us. The hospital and ICU say your loved one needs 24/7 ventilator care and can't go home. Or you need to find a long-term facility or a nursing home, which won't look after a ventilated client anyway. Or even worse, they're telling you your loved one won't have any quality of life, and therefore it would be in your loved one's best interest, and I put that in quotes, to have treatment stopped and die. That's just cruel, and it's inappropriate. So the information is incomplete. The truth is COPD patients on long-term ventilation and tracheostomy or on BiPAP or CPAP can go home with the right level of support. That support is 24-hour critical care registered nurses, ICU nurses who are trained in mechanical ventilation, tracheostomy care, and acute changes in COPD patients in any environment, whether it's in ICU or at home. But we want to now transition to home care, of course. And this is exactly what we advocate for here at intensivecarehotline.com and what we advocate for at intensivecareathome.com. And obviously, this is exactly what Intensive Care at Home provides. So let's look at transitioning from ICU to home care, advocating for home discharge. As we wrap up this first half where we looked at ICU, what's happening in ICU for COPD patients, I want to talk about the advocacy that goes right along with it. If your loved one has COPD and is on long-term ventilation or has a tracheostomy, you have the right to ask about home discharge with intensive care at home support. Many ICU teams aren't familiar with intensive care at home models, or they assume families can't access this level of care. That's where services like Intensive Care Hotline from an advocacy point of view and Intensive Care at Home from a service point of view come in. We work with families worldwide to understand the medical situation, advocate for appropriate discharge planning, connect families with intensive care at home, and navigate insurance and funding options, of course. You can visit us at intensivecarehotline.com for personalized consultation and advocacy support. The key message: never accept impossible as an answer until you've explored all options. Definitely don't accept that your loved one's only option is to die or to stay in intensive care indefinitely. That's not true, and I will show you in a moment why. Now, before we move on to the second half, let me remind you, if you're finding value in this live stream, please like, comment, subscribe, and share the live stream with anyone that will benefit from this information. Drop any questions in the comment section. I'll address them as we go or at the end. Please keep them to today's topic. And like I said in the beginning, if you want me to cover a certain topic, type it into the chat pad so I can, get something prepared in another video. So let's take a 1-minute break and then we'll dive deep into how COPD patients with ventilation and tracheostomy can thrive at home with evidence-based intensive care at home. Just give me 1 minute and I'll be right back. Okay, let's now look at COPD patients in intensive care and how they can go home with intensive care at home. So, if you've just joined us now, we're talking about COPD patients with long-term ventilation and tracheostomy, or COPD patients on BiPAP, CPAP, and high-flow nasal cannula, high-flow nasal bronchs, and how they can transition from ICU to home with proper support. Now we're focusing in the second half of this presentation, we're focusing on intensive care at home, what it is, how it works, and why it's a game changer for COPD patients in ICU with BiPAP, CPAP, high-flow nasal bronchs, oxygen, as well as invasive ventilation with tracheostomies. And obviously, it's also a game changer for the families. So we will now cover evidence-based mechanical home ventilation guidelines that you can find on our intensivecareathome.com website, the role of 24/7 critical care registered nurses, how tracheostomy and ventilation care works at home, community access and quality of life, non-invasive ventilation at home with BIPAP and CPAP, and real outcomes from our clients. Number one, let's look at safety first and foremost, because what we do with intensive care at home needs to be safe first and foremost, and that's where the evidence-based mechanical home ventilation guidelines come in that you will find on our website at intensivecareathome.com. It's not a new guideline, but it's dramatically underutilized because many healthcare providers and hospitals simply don't know that it's an option. At intensivecareathome.com, we follow best practice, we follow evidence-based mechanical home ventilation guidelines, and you can read these in detail at our website. Now, these guidelines have been around since the late 1990s and early 2000s. They're coming out of Germany, which is really the leading country when it comes to intensive care at home. That's where it all started. And that's where it's been a massive success as well. It has been a massive success in Australia as well, of course, with intensive care at home. But that's where it really all started. I've been following these guidelines from day one. I know these guidelines work because these guidelines establish that, number one, mechanical home ventilation is safe and effective for patients with chronic respiratory failure, including COPD, when proper support is in place. Number two, patients on home mechanical ventilation, whether it's invasive or non-invasive ventilation, experience a much better quality of life, have no or reduced hospital readmissions, improved psychological well-being compared to institutionalized care. And that improved psychological well-being includes the families, of course. And number three, 24/7 ICU nursing care is essential for patients requiring continuous or near continuous ventilation, which includes a tracheostomy. Without ventilation, it also includes ventilation without a tracheostomy. Number four, home ventilation and intensive care at home is extremely cost effective compared to long-term ICU or any facility really. So what that really illustrates that intensive care at home is a win-win situation for all stakeholders, which means patients and families want to be at home. They want to improve their quality of life. Hospitals need to free up the ICU bed, and the funding bodies want to reduce the cost. Therefore, it's a holistic win-win situation. Because the evidence is clear, with the right clinical team, COPD patients on ventilation and tracheostomy can live very safely at home. But the critical component and the critical ingredient here is that those patients need 24-hour intensive care nursing at home, not general registered nurses, definitely not disability support workers or home health aides, not LPNs if you're in the US, not enrolled nurses. It requires 24-hour intensive care nurses, and all of those intensive care nurses need to have a minimum of 2 years intensive care nursing experience, ideally with a postgraduate critical care nursing qualification. In essence, we're talking about ICU trained nurses in the home around the clock, providing the same level of monitoring and intervention you'd receive in a hospital ICU, but in the comfort of your own home. This is the standard at intensive care at home, and it's not negotiable for patient safety. Every time funding bodies or hospitals are trying to negotiate on those minimum standard, people have died. People have died under the care of even general registered nurses, let alone with support workers or family members trying to be intensive care nurses. People have died under this model, and I have evidence to back up what I'm saying here. So let's look at safety. We're sticking with safety here still because safety is absolutely paramount. Why 24-hour intensive care nurses or CCRNs are essential. Let's talk about what critical care registered nurses, CCRNs, actually do for ventilated COPD patients at home. Number one, ventilation management. Critical care nurses, ICU nurses monitor ventilator settings, respond to alarms, troubleshoot equipment issues, adjust settings as needed based on patient status, They also prevent issues such as, pneumothoraxes, etc. Next, tracheostomy care. They perform tracheostomy cleaning, tracheostomy dressing changes, tube changes, inner cannula changes, suctioning to maintain a clear airway. Next, they do respiratory assessments. Critical care registered nurses, ICU nurses continuously assess breathing patterns, oxygen saturation, lung sounds, and signs of respiratory distress. In certain cases, they will also monitor arterial blood gases. And number 4, they can manage emergency responses if a patient experiences ventilator malfunction, airway obstruction, or acute deterioration. ICU nurses know how to respond immediately, no waiting for an ambulance. Now, the best way to deal with this is obviously to prevent emergency responses, right? It's not so much that we can respond to these emergencies. The much better option is to prevent these. One thing that I always say to our staff is, what do we need to do today to prevent a hospital readmission or a medical emergency tomorrow, right? What do we need to do today to prevent a hospital admission or a medical emergency tomorrow, in 2 days, in 3 days, in 2 hours even, right? So we constantly have to be on the ball. But again, that is our skill. Number 6, medication administration. Many COPD patients require nebulizers, steroids, antibiotics, and other medications. CCRNs and ICU nurses manage all of these. Number 7, preventing complications. CCRNs prevent hospital-acquired infections, pressure injuries, deep vein thrombosis, and other complications through evidence-based nursing interventions. But just talking about the infection rate in a home is so much lower, because in an ICU, you have other patients with infections. Doctors and nurses, unfortunately, carry these infections from patient to patient most of the time, even though they're washing hands, they're wearing aprons. It's still, the risk is very high that infections get transitioned from one patient to another. Not the case at home, right? It's a much cleaner environment. And number 8, we provide care coordination. We communicate with doctors, nurses from the hospital if need be, respiratory physios, and other specialists to optimize the care plan. This level of care cannot be provided by untrained family members, general registered nurses, let alone support workers, but need critical care registered nurses to manage all of this, which includes ventilation or tracheostomy care, needs management 24 hours a day. And here is what our families tell us. Having CCRNs and ICU nurses in the home provides peace of mind, provides safety. They sleep better knowing their loved one is being monitored by experts and being looked after by experts. At intensive care at home, all of our nurses are ICU trained, have a minimum of 2 years ICU experience. I believe around 75% of our nursing staff have completed a postgraduate critical care nursing qualification. And, we employ hundreds of years of critical care nursing experience combined in the community. We do not compromise on qualifications or on quality standards because our patients' lives depends on it. So let's look at how tracheostomy and ventilation works at home. Let's get more practical. How does tracheostomy and ventilation care actually work in the home care setting? We obviously need the equipment. Patients have a ventilator at home and a backup ventilator, usually a portable home use ventilator, though some may have hospital grade ventilators, but mainly it's community designed ventilators that can do the same pretty much to any ICU ventilator, but they are just a lot smaller and just a lot more practical for home care. We also have backup equipment, backup ventilator, oxygen concentrators or oxygen cylinders, suction machines, nebulizers, spare tracheostomies, dilators, face masks, ampu bags or resuscitation bags, backup power sources. Ideally, families have a generator at home just in case the power goes down, and so forth. so forth. Next, the bedroom setup. The patient's bedroom becomes a mini ICU. We ensure proper equipment placement, monitoring devices, emergency access, and a safe and comfortable environment for patients' families and also for our staff, of course. We focus on daily routines. Our ICU nurses perform tracheostomy care multiple times daily, cleaning the tracheostomy site, changing inner cannulas, suctioning secretions, giving nebulizers, monitoring for infections, complications, and of course, prevent infections and complications. Next, ventilation management for patients on continuous ventilation. The CCRNs or ICU nurses monitor the ventilator constantly. For patients on intermittent ventilation or BIPAP, our nurses assist with putting equipment on and off and monitors for tolerance. We can also initiate weaning trials if that's indicated. Some COPD patients can gradually reduce ventilator dependency. CCRNs conduct supervised weaning trials, carefully monitoring the patient's response. Obviously, that needs medical oversight, which we can deliver as well. Next, mobility and activities. With CCRN and ICU nursing support 24/7, patients can sit up, transfer to chairs, even leave the house with portable ventilation equipment when appropriate. Let me emphasize this. Our clients at intensive care at home aren't bedridden. With proper support, they participate in family meals, go outside, attend events, and live their lives to the best of their abilities. And compare this to lying in an ICU bed for months or weeks or even years on end. In an ICU bed with no fresh air, with no natural daylight, restricted visiting hours, it just doesn't make sense why anybody would stay there for then an insurance body or a government body to pay $5,000 to $6,000 per bed day for what you can have for half of the cost at home, which is a win-win situation. The difference is 24-hour intensive care nursing at home, which makes all of the intensive care at home service possible safely. Now, let's also look at community access for our clients and quality of life. Living life with mechanical home ventilation. This is where intensive care at home truly shines, which is quality of life. All of our ventilated and tracheostomy clients at home have community access. Let me say this again, community access. What does this mean? Going outside, our clients can go into their garden, sit on the veranda, on the balcony, whatever, their porches, feel the sun on their faces and breathe fresh air. This alone is transformative for mental health. They can attend events with CCRNs and portable equipment. Clients can attend family gatherings, religious services, graduations, weddings, life events they would entirely miss in an ICU. Shopping and dining. Some of our clients can go to restaurants, cafes, and shops with their nurses or other family members. They engage with their communities. With proper planning, we have also gone traveling. Home ventilation patients can even travel to visit family or take vacations. We've done all of that. We've been on airplanes with some of our ventilated clients. I'm not making this up. One of our tracheostomy clients a few weeks ago went on a cruise for a few days. All possible because they have 24-hour critical care nurses. Right? And again, this saves a lot of money. Now let's look at social connections. Being at home means constant access to family and friends. Children can visit freely. Spouses can sleep in the same bed. Life continues. Compare this to ICU. No outdoor access, restricted visiting hours, no community engagement, complete isolation from normal life, sensory deprivation, sleep deprivation, loss of autonomy. At home, you can tell us how you want your day to look like. In ICU, the ICU will tell you what your day will look like. And that's simply not good enough. The psychological impact of being at home versus being institutionalized cannot be overstated. Our clients tell us they feel human again. Our families tell us they feel human again. They feel like themselves. They have purpose, joy, and connection. And this isn't just anecdotal. Evidence shows that patients receiving intensive care at home have lower rates of depression and anxiety, better cognitive function, improved family relationships, higher satisfaction with care, greater sense of dignity and autonomy, because once again, you can tell us how you would like your day to look and how your routine needs to be done by us. And this is what's possible when you combine evidence-based clinical care with compassion and a commitment to quality of life. If you want to learn more about intensive care at home, visit intensivecareathome.com. Let's also break this down into non-invasive ventilation at home with BiPAP and CPAP, right? So let's circle back to that, what we talked about in the beginning, that many COPD patients in ICU start out on BiPAP or CPAP to avoid intubation, which is really important. And when intubation can be avoided and they can have BiPAP, CPAP, high flow nasal cannula, high flow nasal bronchs, they can also be transitioned home safely, because even for them, the outlook is to stay in ICU long term, because BiPAP, CPAP management still needs critical care nurses 24 hours a day, right? So at intensivecareathome.com, we support COPD patients on non-invasive ventilation such as BiPAP or CPAP at home, including high flow nasal cannula or high flow nasal bronchs with the Airvo machine. So why do they need 24-hour nursing care? Well, for example, mask intolerance. BiPAP and CPAP require tight-fitting masks, which can cause skin breakdown, discomfort, and anxiety. CCRNs help with mask fitting, breaks, and skin care, right? Also, a lot of COPD patients may not be strong enough to put the mask on and off. They may also not necessarily know when it's indicated to put the mask back on and off. Another thing that we do at home is do arterial blood gases when needed. We can do that with an iStat machine, right? Of course, you want to monitor CO2 and PO2 without arterial blood gases, but the gold standard is really to do blood gases at home as well, which includes, having an iStat machine available at home. Another reason you need 24-hour nursing care at home with critical care nurses if you're on BiPAP or CPAP with COPD is aerophagia. That means some patients swallow air with BiPAP, causing bloating and discomfort. Nurses monitor for this and adjust settings or positioning. There's also a higher risk of aspiration when patients swallow air with BiPAP or CPAP. Also, BiPAP needs or CPAP needs equipment management. BiPAP machines can malfunction or alarm. You need to be able to interpret the alarms. You can't just switch the silence button and not knowing why you're switching off the silence button. There could be an alarm because a patient has a pneumothorax or a barotrauma, which means they have a hole in their lung, right? So similar to ICU, right? Or ICU nurses need to listen to the patient's chest continuously, especially with COPD, making sure there's enough air going into the lungs, otherwise there's no point. Also, our nurses need to monitor ventilation tolerance, because not all COPD patients at home can tolerate non-invasive ventilation equally throughout the day or at night. CCRNs assess the respiratory status and know when to escalate care if needed. Also, another very important factor is that at home, intubation and hospital admission needs to be avoided. With proper BiPAP or CPAP management at home, many COPD patients avoid hospital, ICU readmissions and intubation, which is absolutely critical. The goal of having CCRNs and ICU nurses manage non-invasive ventilation at home is to maximize patient comfort, optimize respiratory support, prevent complications, keep patients out of ICU, maintain quality of life. We've had numerous clients with COPD on continuous BiPAP who live full active lives at home because they have the 24-hour ICU nursing support. Remember, whether it's invasive ventilation through a tracheostomy or non-invasive ventilation with BiPAP, CPAP, high-flow nasal prongs, high-flow nasal cannula. The common denominator is really having expert nursing care that is evidence-based according to the mechanical home ventilation guidelines, because that is what keeps patients safe. That is what makes home care absolutely possible. So we are coming to the end of our time together today, so let me bring this all home. If your loved one has COPD and is facing long-term ventilation, tracheostomy, or continuous BIPAP, CPAP, or high-flow nasal cannula in the mix, you have options. You don't have to accept indefinite ICU stays or institutional care facilities, or a talk about end of life, saying, oh, it's in your loved one's quote-unquote best interest to have treatment removed, because if they do survive, they won't have any quality of life. Nothing could be further from the truth. We have proven this over and over and over again. Because with 24/7 ICU nurses at home, COPD patients can receive evidence-based intensive care at home, maintain community access, and live with dignity and quality of life. So, if you need help navigating an ICU situation right now, and you need advocacy to take the first steps, go to intensivecarehotline.com. We provide ICU consultations, advocacy, and support to help families in intensive care understand their options and make informed decisions. If you're interested in intensive care at home for yourself or a loved one, go to intensivecareathome.com. You can learn about our service, read our mechanical home ventilation guidelines, and contact us to discuss whether home intensive care is right for your situation. Also, like I said, subscribe to this YouTube channel. If you enjoy my videos, click the like button, click the notification bell, and share this video. And if you're watching this on replay, please leave a comment letting me know what you found most helpful or what questions you still have. I read every comment. And if you want me to cover another topic that's intensive care or intensive care at home related, please let me know. I really want to thank you for spending your time with me today. I'll do another live stream again next week. Until then, stay informed, stay empowered, and know that there are always options. I also encourage you to check out intensivecarehotline.com. We have a membership for families of critically ill patients in intensive care there. I also provide one-on-one consulting and advocacy. We also review medical records. And with intensive care at home, like I said, we provide full intensive care services at home. With 24-hour intensive care nursing, we employ hundreds of years of critical care nursing experience combined. And we also provide level 2 and level 3 NDIS support coordination, WorkSafe, and TAC case management as well. That's it for today. I wish you a good Sunday, a good weekend. Look after yourself and take care. Now, with intensive care at home, we are currently sending our ICU and critical care nurses into the home 24 hours a day. We are providing the following: home care services for ventilated adults and children with tracheostomies with critical care nurses 24 hours a day. A genuine alternative to a long-term stay in intensive care or long-term acute care. Tracheostomy care for clients without ventilation. Home care services for patients on non-invasive ventilation such as home BiPAP, home CPAP. Home TPN, which is also known as IV nutrition. Home IV potassium and home IV magnesium infusions, IV fluids, and IV antibiotics. We are providing central line management, PICC line management, Hickman's line management, as well as port management at home. We're providing nasogastric tube and PEC tube management at home. The use of cough assist machines for our clients for airway clearance at home. Palliative care services at home, as well as ventilator weaning at home. We're also sending our critical care nurses into the home for emergency department bypass services. We have done so successfully as part of the Western Sydney Local Area Health District, their In Touch program, saving approximately $2,000 per patient that we keep at home instead of them going to an emergency department. That also means we're in a position to cut the cost of an intensive care bed by around 50%. An intensive care bed costs between $5,000 to $6,000 per bed day. Our service costs between $2,500 to $3,000 per bed day, and we're freeing up the most sought after bed in the hospital, which is the ICU bed. Most importantly, we're improving the quality of life for patients and their families which is a win-win situation for all stakeholders. Of course, quality of life is much improved surrounded by families and by a team of dedicated intensive care nurses in the home care setting instead of in an intensive care unit. With intensive care at home, we are currently operating all around Australia in all major capital cities as well as in all regional and rural areas. We work with NDIS clients all around Australia, TAC and WorkSafe in Victoria, Department of Veteran Affairs all around Australia. Our clients and we as a service provider have also received funding through public hospitals, private health funds, as well as departments of health. We are having policies and procedures for intensive care at home nursing, and we've built all the intellectual property for intensive care at home since 2012. No other provider in Australia has created more intellectual property when it comes to intensive care at home nursing than we have. This puts us in a position to employ hundreds of years of critical care nursing experience combined in the community. No other service provider in 2025 employs a higher skill level in the community than we do, which enables us to look after the highest acuity adults and children in the community in Australia safely. So if you're at home already and if you're watching this, or you're stuck in an ICU long term, or if you're going to hospital and ED all the time and you realize that you don't have the right level of support at home, or if you are stuck in an ICU, I'll give you a real world example today how we can help you. One of our first clients when we first got started in 2012 was a client who was at home initially on a ventilator with a tracheostomy with a support worker model 24/7. Of course, support workers are not equipped to look after a client at home on a ventilator with a tracheostomy. That is dangerous and it's simply negligent. Having support workers looking after a client at home on a ventilator with a tracheostomy is like flying the airplane with a cabin crew instead of the pilot, because anyone on a ventilator with a tracheostomy is at very high risk of medical emergencies 24/7, or even at high risk of dying if they don't have a team of dedicated critical care nurses looking after them 24/7 at home. This is actually evidence-based and is documented in our mechanical home ventilation guidelines that you can find on our website at intensivecarehome.com. Think about it. In an intensive care unit in a hospital, you wouldn't have support workers looking after your critically ill loved one or after any critically ill patient on a ventilator with a tracheostomy. So why would anyone in their right mind do that in a home care environment in the community? So this client at the time found out about us eventually, and the ICU that he was basically living in also knew about us and eventually reached out to us. And we were proving our concept with this client very fast. When we worked with this particular client, we sent him critical care nurses 24 hours a day, and he never ever went back into ICU ever again, as long as we were working with this client. We can do the same for you if you're not safe at home and help you with keeping you at home predictably. Otherwise, we would not be in business. Again, the same is applicable for those stuck in an ICU, similar to this case study that I've just given you. Or if you're going back to ED all the time, please reach out to us. We can help you with taking you through the right steps, including how to get funding with different funding bodies. This is also why we are providing NDIS support coordination. We have a team of NDIS support coordinators, and they have a wealth of knowledge. I've done an interview with Amanda Richards, one of our NDIS support coordinators, and I'll put a link to an interview with Amanda in the written version of this blog. We're also providing TAC case management and WorkSafe case management in Victoria with Lucy McCodder. If you're an NDIS support coordinator or a case manager from another organization watching this and you're looking for nursing care for your participants, please reach out to us as well. If you need more evidence for nursing care, we are also writing NDIS nursing assessments with legal nurse, critical care consulting nurses. If you are a critical care nurse and you're looking for a career change and you want to join a very progressive, dynamic and high-performing team of critical care nurses in the community, we're employing hundreds of years of critical care nursing experience combined. You can join this high-performing team if you are a critical care nurse. If you are looking for a career change as a critical care nurse, we're currently hiring for jobs for critical care nurses in Melbourne, Sydney, Brisbane, in Albury, Wodonga, in Bendigo, in Geelong, in Warragul, in Victoria. If you have worked in critical care nursing for a minimum of 2 years, pediatric ICU, ED, and you have already completed a postgraduate critical care nursing qualification, we will be delighted hearing from you. I do have a disclaimer though, because we are offering a tailor-made solution for our clients, which includes regular staff. Our clients also do want the same staff coming over and over again because they are so vulnerable and so special. That's why we need regular staff. So if you're looking for agency work where you can come and go, this will not be the right fit for you. We are looking for consistency and our clients are looking for consistency. So please only apply with us if you can give us regular and consistent availabilities for shifts and you're really keen on building solid relationships with us and with our clients. If you're an intensive care specialist or an ED specialist, we also want to hear from you. We're currently expanding our medical team as well. We can also help you eliminate your bed blocks in your ICU and in your ED for your long-term patients or for your regularly readmitting patients with our critical care nursing team at home. We're here to help you take the pressure off your ICU and ED beds, and in most cases, you won't even pay for it. Even if you do pay for it, it is so much more cost-effective than what you're paying for in ICU and ED, and you get the same level of care. And if you're a hospital executive watching this and you have bed blocks in your ICU, ED, and respiratory wards, or for home TPN, please reach out to us as well. We can help you eliminate your bed blocks very fast. If you're in the US and in the UK, and you're watching this and you need help, we want to hear from you as well. We can help you there privately with one-on-one consulting and with hiring nurses privately. Once again, our website is intensivecareathome.com. Call us on one of the numbers on the top of our website or simply send us an email to info@intensivecareathome.com. And if you like my videos, subscribe to my YouTube channel for regular updates for families with intensive care at home and intensive care. Click the like button, click the notification bell, share this video with your friends and families, and comment below what you want to see next or what questions and insights you have from this video. Thank you so much for watching. This is Patrik Hutzel from intensivecareathome.com, and I will talk to you in a few days. Take care for now.